yeah, that should be
the way forward.
Yes.
Okay. So I believe those stuff has been installed in this both isolation ward.
In addition, eye protection. Sorry, I couldn't mention eye protection.
Right. Okay. And let's move to KJ again. KJ, do you know now? We know we have a resident physician referral system operating in our hospital for the non-medical wards. Do you know the figures about COVID-related resident referrals happening so far during the last month?
Yeah, in fact, so that we have a very good system, as you explained, and during the daytime we have a resident physician station, and then also off time there is an on-call physician who acts as a resident physician. So we have had more than 25 referrals from other specialties, surgical, cardiology, oncology, and ICUs. Out of now, most of them have basically developed fever during their hospital stay, and that shows that our screening at the OPD has been quite effective. Now, out of these patients also, few fulfill the criteria for testing, and we have tested about 7 of them, and all had been negative. So that is the state of referrals from other specialties for COVID and therapy.
Right. Bhagya, can there be a transmission from an asymptomatic patient to a healthcare worker? Can you give us an idea about this? I know
Yes. So if the healthcare worker is wearing the proper appropriate PPE from an asymptomatic patient, it's very, very unlikely to have a transmission.
All right. Okay. Thank you. Now, in IDH agent, lots of patients are being managed. Has any one of those staff got infected from these patients?
Yes, it's an interesting point actually. So now IDH actually they manage a lot of diagnosed patients, and they also have some unsorted patients as well. But we luckily there had not been a single case of a positive case in any of the staff members who are involved in clinical practice, and so that is quite encouraging to the healthcare workers in our institutes as well.
Okay. So Bhagya, with that note, now there's no significant transmission from diagnosed patients to IDH staff. We are not heard about it. And with that, can you enlighten this esteemed audience about, let's say, if you have arranged care for a suspected COVID patient in your ward, do you have to really worry about it? If, say, you are wearing adequate PPE and arrange the necessary care, do you really have to worry about it?
First, most important thing, don't panic. And so, again, if you have worn an appropriate PPE, even for with a positive patient, then we have as I told you, there's a level of exposure, risk of exposure, as I said. So we have to assess the risk of exposure according to the patient status and the healthcare workers PPE the healthcare worker had worn at that situation. And there's an expert panel to assess the risk of exposure. And according to that category, it will be assessed and the appropriate action will be taken. So the thing we should emphasize is we are taking all the precautions not to spread the disease to the family of the healthcare worker or to the community. And the healthcare worker's protection is assured at best.
Right. And we've got another question from our audience. I know there are a lot of the doctors working in the peripheral stations have logged into this session. So, can you give particular advice for these peripheral hospital doctors about this PPE?
Yes, again, in the goal district, we don't have evidence of community transmission. And again, in the peripheral hospitals also, we have a triad system, and there's an interim ward most of the time. So in the routine wards, again, if you can maintain the spatial distance of 1 meter, that is best, and wear a mask. And but again, if you have any suspicion, if the patient is allocated to the interim ward or the isolation ward, then you should wear full PPE like face mask, gown, gloves, eye protection, and everything.
So it's basically like the same system that we've been running.
System we run.
Okay. And there's another question from the audience for Naomi. It says the question is about the different methods of sampling. I also have seen samples collected from nasopharynx, oropharynx, tracheal aspirations. She or he is asking what is the best sample collection method that you are advising.
Yeah, we know there are several methods of sample collection, but we would say depending on the patient's clinical symptoms, we would get the sample. Like for example, if coronavirus is a virus which basically infects the lower respiratory tract. So if we can get a lower respiratory tract sample, that would be the ideal. It's very difficult to get a lower respiratory tract sample in a normal patient. So therefore, we would go for a convenient sample. The best sample would be a bronchoalveolar lavage or a endotracheal aspirate, which we can only get from a patient who is intubated. But if we can't get that sample, the other samples would be a nasopharyngeal swab, oropharyngeal swab, or a nasopharyngeal aspirate. But mind you, it should be a nasopharyngeal, not a nasal or a throat swab. The nasopharyngeal swab would go deeper than a nasal swab. But if you get an isolated nasopharyngeal swab or a oropharyngeal swab, the yield would be less. Therefore, for a normal patient, we would recommend a combination of nasopharyngeal and an oropharyngeal swab.
Right. And there's another question about this testing. How reliable is to exclude corona with one negative report?
Just one thing to the previous one, sputum is another sample we would recommend for a patient who is having a productive cough, rather than a nasopharyngeal and an oropharyngeal swab. A deeply cough, spectorated sputum would be the best sample rather than going for a swab. And regarding the sensitivity, they're asking the sensitivity of the test. I don't think any test in this whole world can 100% exclude an infection, right? But we can get a lower respiratory tract sample, for example, a sputum sample in a normal patient. If it is a bronchoalveolar lavage or an endotracheal aspirate, the sensitivity would be around, more than 90%. If it is a sputum sample, the sensitivity would be about 80%. But if it is an isolated nasopharyngeal swab, the sensitivity is around 60%. That is why we recommend a nasopharyngeal plus an oropharyngeal swab to increase the sensitivity. So it's not 100%. Therefore, there can be false negative results we admit. That is why if you have a high clinical suspicion, we would recommend a repeat sample in 2 to 3. That is what is recommended in the study.
Now, with that note, I would like to ask KJ, what's really happening in IDH? Let's say if you have a very high suspicion of COVID in clinical grounds and the sample become positive, what are they doing for that type of patient?
Yeah, so they do have, so they do all the precautions of isolation, and they do have special treatment modalities also. And they have actually at the moment they are given some oral hydroxychloroquine as mode of treatment, and they are well monitored. Now, as I have explained to you before, sometimes during the course of the illness, day 7, day 10, they might go into some sort of a respiratory distress. So they have been well monitored, and then once they basically they do PCR testing to make sure that they are non-infective on discharge, and if there are two samples, consecutive samples are negative, they are sent home.
KJ, that's right. But let's say in the beginning of the illness, the history is suggestive.
Yes.
The fellow has contact history or a foreign travel, but the sample becomes negative. What do they do?
So then they will do a repeat sampling. Usually within 24 hours, they will do a repeat sample and then take it from there. So whether depending on the sample, they will act accordingly and the symptomatology also.
Right. Thank you. And there's a question to our provincial director, Siritunga. I would read out the question. Colombo things got out of control with drug addicts. Do we have thought of ways of addressing it? I know it's a sort of discussion taking place at ministry level right now, but could you put some more light on this?
You mean the risk people
in Colombo? He's asking about the Colombo area.
Yeah.
To prevent further community transmission from these Galle and Bandaranaikapura cohorts, what are the possible ways of preventing further community transmission?
You mean in Colombo?
In Colombo.
No, actually the basic theory is to find out the contacts and isolate them and test it and random something if necessary. So anywhere you can do this kind of thing. That's now we have to, in basic theory, we have to get the contacts and act accordingly. So that is happening in Colombo at the moment. So they trace all these drug addicts and then they isolate and test it, and that is the, so this is the basic. I mean, here also if there are any risk category, we have to find out them, and otherwise so
right. And thank you. And there's a question to Bhagya.
at the moment now this Navy issue is there. I don't know whether now
that's I want to have a chat with you about it. Yeah.
So that's also out now. That's according to their sources now. About 4,000 naval officers were there in that Venezuela camp, but only few isolated areas they were positive in some camps, like even though it's a big camp, there are two buildings. So they have tested all this. Now they are going to test, and some people on leave when they were in the community, and we traced them, and they also informed us, and some of them returned to the Navy base now. And now our people, now they are house quarantine. So within the province there are about 50 people are there, like all the homes are quarantined, and we do the testing. Yesterday in Galle we have done 9 samples, no? 9 samples or 8 samples, and all were negative. Yeah. No, yeah. In all now these officers now we all were negative, and today they also give some samples. So if they get positive, we do accordingly. So that is we get here and now there are this type.
So this quarantine people, do you do only one sample or do you repeat it?
No, that depends. That depends. If it's a very high risk patient, we do a repeat sample is the first one.
Right. Now I want to ask a specific question from Nalo, since this question came up. The samples from Navy officers who are residing in Galle or have come to this booster Navy camp visiting the Valley Cellar, you have done some samples yesterday. How many you have done?
We have done around 35 samples,
35.
not just Galle. We have got samples from Galle area also. So in Galle, basically, we have done around 25 samples. Around 35 samples yesterday, and we are expecting some more samples, as Dr. Siddhipunga said today also.
So those 35 all were negative, am I right?
Just one positive from Galle.
Okay. But all from Galle?
All from southern province, the ones that we got.
Right. Right. Now with that note, yes, this question is for Bhagya. Different colleges release recommendation on use of PPE when performing different procedures. What do you recommend as suitable PPE when handling asymptomatic or no contact? I think we have elaborated on this before, but could you just brief on it?
Yes, asymptomatic or non-suspected patient. It's like a routine mode patient. So it has no contact history and asymptomatic. If you can maintain 1 meter distance, that's better, and you can wear a PPE, the patient face mask. And if you want to physically care for the patient, then face mask and the gloves. And the most important thing is hand hygiene. Actually, I couldn't elaborate on that. At the same time you are wearing PPE, you have to give a big space for your hand hygiene, because if you are adhering to the WHO 5 moments of hand hygiene, actually your protection is more secure.
Right. There's a question from the audience. I believe KJ could answer this. What are the advices can be given to GPs about their practice? Now, we know, GP care is not happening now, but most likely it's going to be opening very soon. So is there a piece of advice, KJ?
Yeah, one reassuring thing was that now all the expert panel, confess that there is no community spread. But that doesn't, give us an excuse. But what I suggest is have some sort of a triage that is being, not the same thing, triage that has been practiced in the hospital in your practice as well. For example, you can have a telephone consultation on patients who are presenting with respiratory symptoms, and then you can ask about the travel and contact. In those patients, definitely you need to refer to the preventive aspect of that area. Through them, you can send them via 1990 to the hospital for further assessment. But as you know, most of the other patients, majority are non-COVID, but you need to stick to your basics. That is, stick to your recommended PPEs, and then you can continue your practice, but be little alert, though there is no community space. That is a small advice that I can give.
Right. There's another interesting question. Are there any patients, maybe in island-wide, who develop other systemic symptoms other than respiratory due to COVID? So for you to answer that, I think IDH cohort would give us some light pages.
Yes, that's right. That's a very interesting question. Actually, we as a country have been a little lucky, because most of our patients who majority had respiratory symptoms only. And the complications that we had were mainly for patients who had some pre-morbid status, or in one case, probably the virulence of the organism. The rest actually, so we didn't have many cardiac, renal, or cerebral involvement, other than the secondary sepsis some of these patients had due to bacteria.
Right. And there's another comment or question. I think partly we have addressed that. Is there a community or cluster transmission? We clearly said in Galle and southern region there's community transmission. Is there a cluster transmission in southern province, No. How about what's happening in Colombo? Is it community transmission? Is it cluster transmission?
In Colombo, there are in Galle, that's the cluster, no? So that can be considered cluster transmission, but here we don't get that at the moment. In Colombo, yes. Kesselvat area especially, we have considered it as a, because that's a cluster. So about 86 patient positive at the moment from 200 on. So that is considered as a cluster. Yes.
There's another question. I believe Naomi could enlighten us about this. Would like to know whether we are cross-checking our diagnostic measures with other labs and sensitivity of tests.
Of course, we do. We have done, I think, several times because fortunately, Southern Province has reported less cases, and we were also very worried that why are we not detecting cases, which is a good thing. But then it's not good for the laboratory reputation. So we have got positive samples from IDH initially to validate our PCR. I have to tell you, the PCR test is one of the very sensitive tests we are having at the moment. But the problem with the sensitivity is solely depending on the sample. Right? If you get a good sample, the sensitivity of PCR would be more than 95%. It's very good. So we are in the laboratory, but so we have to look at two things. One thing is getting a good sample, and the other thing is doing the test correctly. So for getting a good sample, we have been training and we have been monitoring. We have been regularly updating the nurses and the people who are taking the samples inside the hospital as well as outside. And we have advised them how to maintain the temperature, how to transport and everything. And we are continuously educating them to get on a good sample. That's number one. And then in the laboratory, performing the test. So we have a very good trained staff and very committed. And we have been evaluating. And every time we get a new kit, we do a validation before doing samples with known positives and negatives. And for inter-laboratory cross-checking, we have done twice. I think probably we would be the only language whom have done twice the test, because first time we got down positive samples from IDH, and we did a dilution with low positives to make very low positives and high positives, and we have tested with the available kit. And the next time, because we were getting very all negative results, we were a little worried about the test. Actually, the test was working fine, the controls were working fine, but just for our we wanted to compare our test. So we personally have gone to Ragam and have got down many samples positives, and we did a dilution to make the samples very low positives and did the test, and the test is working fine. There's no issue with the PCR test, but the only worry is to get down a good sample under ideal conditions that we are regularly monitoring. So there's no, very, very minimal chance that in the laboratory to get a false negative result.
Right. There's a question to Dr. Siritunga about the exit plans. What do you recommend for opening government offices and institutions and practical? What do you recommend about this exit plan?
Actually, that is the government. And we have now about 1 month. We were in a curfew state, so nothing has happened in the country. So government wanted to open at least a partial way to restart all these some of the government offices, essential, some of the main offices, and especially for the economy of the country and for people of daily people and all these things. So now considering it was considered at that time there were the prevalence of the disease of these provinces like Southern and some of the other provinces were not that scientifically no one could say that we should close down for some time. So that's what now government opened these things. Now they have recommended only 50% of the employees to come to the offices like that, and some of the offices were not open. Especially some of the private offices, private sector factories were not open yet. So, but the issue is public transport is not at the moment. It is not sufficient for the people to come. So, still we are using some other means of transport and things. So as there is no community transmission, so we can't. Anyone cannot say that we should stop at this level and so forth. So we recommend that kind of thing, but otherwise no gatherings, no pilgrims, no trips. When this inter-district transport is also restricted. Even the highway is now restricted from Balipan. I think they exit and things like that. So that is happening with the restriction. So that is the current situation. With we'll see what will happen. So that is you can't no gatherings, no trips, no any other. So, yeah.
Right, Chandra, thank you. And another question to Naomi. Now there's been a big discussion about antibody-based tests. So what is the place for antibody-based rapid assessment test in mass screening?
We all know antibodies, the body's response to an infectious disease. So antibodies would take some time to develop. Some infections, antibodies for some infections would develop faster than some other infections. When you consider this COVID-19, according to the data available at the moment, the antibodies would take around 12 to 14 days to come. So at the moment, currently, for diagnosis, no place for the antibody test. And for mass screening, what I would say is this antibody test, there would be some place, but it's not for acute diagnosis, but for mass community screening, antibodies could come handy. But the only thing is, if there's no community transmission in an area, I don't see the place for antibody testing in community transmission. But of course, in places where there's community transmission, the antibody test could play a role for surveillance.
Right. And so we are nearing the allocated time slot for this. And there are another two questions. One thing related to Bhargya. This is a comment basically. I think there's a phobia among healthcare professionals in using personal protective. Do you have any comment on this?
Actually, you shouldn't have any phobia. PP is for our personal protection. That's why it's called personal protective equipment. As care workers, we can't deny treating patients. But at the same time, while caring for the patient at best, we have to have our own protection as well. So, for the appropriate level of PP is needed for each and every healthcare worker. So, just because that you have to wear PP, you shouldn't have any phobia. You should be thankful for the opportunity to wear PP rather than getting exposed.
Right. I think if you rephrase this like this, do the healthcare workers have a phobia in arranging patients' care these days? Especially for this suspected, thinking that this is a suspected patient. Can KJ give some thought about it?
I think at whatever the cost now, whatever the cost, the patient care should not be compromised. So because if there is any suspicion that there is appropriate PP, there is recommended PP, with that you need to attend to the emergency and save patients' life or offer the standard of care, and we should not deprive them of their standard of care.
So the nutshell would be there shouldn't be any phobia if you are practicing appropriate PP. It's called protected exposure, isn't it?
Yes.
I mean, when you go through this healthcare worker exposure tool, if you are wearing protective personal equipment which is appropriate to the case, you tick as you will be counted as very mild risk.
Yes.
So there's no any quarantine thing imposed.
Yes.
Right. With that note, KK, do you have any idea about non-COVID deaths which has happened during last month or so after the starting of this COVID epidemic?
Yeah, it's quite interesting because now even there was a very recent NEJM article which is happening worldwide. Now, apparently, this non-COVID deaths are more or less sometimes more or less equal in some countries. So the basic reason is because of this COVID phobia, the patients are not offered the standard of care, and I think as what we have explained before, with the appropriate protection, you need to attend to the patient's needs, and all the emergency care should be offered to these patients.
Right, now I think we have...
Can I add one thing?
Sure, go ahead.
For an example, these months, the February, March and April, according to our database, actually it's a pneumococcal peak, right? So patients can, especially elderly patients, can come with pneumococcal pneumonia. So just then, for example, the day before yesterday, there was a patient, 84-year-old lady, put on the isolation unit because of the respiratory distress. But on the same day of admission, the blood culture became positive for pneumococcal, and the patient expired. So we have to bear in mind that there are other causes coming in for pneumonia other than COVID. So we have to give the maximum care for that patients.
In fact, in the case definition, it is said that unexplainable pneumonia. But do you think, KJ, is that the way that we are practicing right now, or are we trying to exclude COVID as the first case, first cause?
I think people have forgotten this unexplainable. For any pneumonia nowadays has become a bit of a COVID phobia or a COVID pneumonia, and probably because of that, of course, the staff panic, and then usually the standard of care, initial care, is definitely not offered in some instances, which is very unfortunate.
I think this pneumonia and respiratory distress are in the case definition just to prevent community transmission. And in the case of community transmission, we do have to consider this, isn't it? Right. I would like to end this important webinar. But before that, I would like to ask all our expert members to give the audience something in nutshell. The things that you have described in one sentence, a message to the audience. Can I start from Bhagya, our consultant microbiologist?
So, believing the system is in place. Without that belief, actually can't work. So you have to believe in the system, wear appropriate PPE according to the exposure, anticipated exposure, and perform hand hygiene according to the WHO 5 modes.
Right, thank you. Naomi, what is your concluding message to this audience?
We have tested many patients. So we have tested pneumonias, we have tested postmortem samples, we have tested close contacts, but none of them have become positive up to now. So at the moment in southern province, there's no community transmission. And the other thing I want to highlight is we have a very good lab at Karapiti, and for the entire southern province, we can create that without any problem.
Of course, I would like to add a bit salt onto it. And we were the second place for PCR testing after MRI. So thank you, Naomi, for that. And Provincial Director, Dr. Chandra, what is your concluding message to the soldiers?
Yeah, at the moment, there is no community transmission, and we will take all the efforts to prevent COVID transmission within the province in a community setup. Thank you.
Right. And finally, what is your concluding message
Yeah,
to the audience?
Okay, what I want to actually confess is that we should treat all patients on merit. And we know there is no community spread, and we should not deprive patient of their standard of care, and we should not risk patients' life, and we should attend to all the emergencies if needed with appropriate PPEs.
Right. I think with that note, we have come to the end of this important webinar. So we have conducted this to cover 4 aims: to arrange the best possible care for COVID-19 patients. We said we have a very good system, very good screening, and then to keep our best standards of care for non-COVID patients that we have elaborated, and then to arrange the maximum protection of our staff members that we have discussed in length, and to prevent community transmission in Galle and Southern province, which our provincial director has clearly mentioned that he has taken all the necessary steps as a community, and even from the hospital side we have taken all the necessary precautions. So with that note, I would like to request our members and viewers believe in this system in place in Galle, Karapitiya, and in the Southern province. Let's arrange the best possible care for these COVID patients, suspected ones, and especially non-COVID ones as well as the way we've been doing. I mean, in time to come, we know there will be a lot of leptospirosis, dengue patients coming. So we have to be with them. For us to be called Suva, we need to be with them. We have a good system. So let's have a hope that it wouldn't go into our community, and we will be arranging the best possible care for all these patients. Finally, I would like to thank again the President Galle and Secretaries, Dr. Galle and Galle, and our Treasurer, Professor Mahinda Komulathi, for his wonderful technical support, and all of you who have joined with us and who have sent all these questions. Unfortunately, we couldn't answer some of them because the time constraints, but we hope to join with you in let's say in weeks or 2 weeks time if we have time. And with that note, I wish all of you a very good day. Thank you.